Thank you, Manish, and thank you, AstraZeneca, for giving me this opportunity. Uh, so the task given to me today is the optimal management of EGFR mutated non-small cell lung cancer patients, and we are talking about metastatic patients here. So to start the talk, so let us talk about the incidence and mortality of lung cancer. And we know that it is one of the most common cancer diagnosed worldwide. And as per the Globocan 2018, so it has got most amount of mortality attributed, which is to lung cancer. And if we see 11.6% of all lung cancers, so they are 11.6% of all cancers are lung cancers, and it contributes to 18.4% of all cancer related death. So in particularly EGFR mutated non-small cell lung cancer, metastatic non-small cell lung cancer. So we have lot of agents which are available, lot of strategies which are available. So we have option of targeted therapy only, EGFR directed targeted therapy only. So then we have the option of EGFR directed therapy along with VEGF monoclonal antibodies. Then we have strategy of using EGFR targeted therapies along with chemotherapy. So we do have lot of strategies. So, but after getting so many of the drugs which are available to target this particular subset, so which drug to use? So this is the biggest question as of now. And I think everybody will agree that we should use the best drug in the first line, because the first chance is the best chance. After that, maybe the patient will not be able to take the drug in the subsequent line, or the performance status of the patient becomes worse and they are not candidate for some other therapies. So now we will discuss about these aspects only in the presentation, and we will come to a conclusion. So which drug to be used in this subset? So we have first generation EGFR TKI like erlotinib, gefitinib. So they can be used as a single agent, or they can be used along with chemotherapy or VEGF directed therapy. Then second generation EGFR TKI like afatinib and dacomitinib, and the third generation TKI, which is osimertinib. So we will discuss all these agents one by one, and we will compare it with the best agent available, which is osimertinib. So as per the NCCN guidelines, so in EGFR mutated metastatic non-small cell lung cancer, so if the EGFR mutation is discovered prior to first line systemic therapy, so then the EGFR directed therapy is the first therapy of choice. And if the mutation is detected during the first line therapy with chemotherapy, then we have two options: either to switch from 1 second, please. 1 second. I will have to connect my charger because my battery is going low. So I'm very sorry. So, and if the systemic therapy has already started, so we have two options. One is to immediately switch to EGFR directed therapy, or the other is that we can continue with the chemotherapy, and as a maintenance strategy, we can use the EGFR directed therapies. So what is the difference between a first generation, second generation, and third generation EGFR TKI? We can see over here that these all agents, they inhibit EGFR mutations, but the mutations which are inhibited by first, second, and third generation TKI, they are different. So the first generation TKI most often they inhibit the del19 and L858R mutations, which are the drug sensitive mutations. The second generation TKI, apart from these sensitive mutations, they also block some of the uncommon mutations. But both of these categories of agents, first and second generation agent, doesn't have any activity on T790M mutation. So osimertinib has got a additional activity on the T790M mutation. Apart from that, if we see the reversibility, so first generation agents, they are reversible blockers, and second and third generation are the irreversible blocker. And if we see the very important point of blood-brain barrier penetration or CNS penetration, so it is minimal with the first and second generation TKI vis-a-vis significant CNS penetration with the third generation agents. So these are certain differences between these agents. Here we can see, so this is the osimertinib molecule, which is in the blue color. So it blocks the common mutations, exon del19 and L858R. It also blocks the T790M, and it has got a very high response rates in these subsets. But it has got a wild type EGFR sparing effect. So with this wild type EGFR sparing effect, so the side effects profile of osimertinib improves as compared to first generation and second generation TKI. It has got less diarrhea, less skin rashes. So it improves the quality of life when the third generation TKI is used because of this wild type EGFR sparing. So this is the first line trial of osimertinib in EGFR mutated non-small cell lung cancer, and it was a phase 3 double-blind randomized trial to assess the safety and efficacy of osimertinib vis-a-vis standard of care EGFR TKI, which was first generation TKI at that point when this trial was started. And this was the trial schema. The flora included those patients with metastatic non-small cell lung cancer or locally advanced unresectable non-small cell lung cancer with exon 19 deletion or L858R. That means they only included the common mutations, and they also included the stable CNS metastasis. So this is a point worth noticing that they included CNS metastasis patient, and these patients were randomized in 1:1 fashion into osimertinib arm vis-a-vis standard of care EGFR TKI, which were first generation TKI at that point of time, and either gefitinib or erlotinib was given on the basis of physician's choice. And the primary endpoint of this trial was progression-free survival, and the secondary endpoint was overall response rate, duration of response, disease control rate, then the depth of response, and even overall survival. So here, the stratification factors were the type of mutation, exon 19 vis-a-vis L858R, and the race, Asian versus non-Asian. And if we see in this trial where the EGFR TKI standard of care were given, so these patients were eligible for crossover, and these patients on progression, if T790M was positive, so they were candidate for osimertinib, and they were given osimertinib in this subsequent line. So this was the initial PFS analysis, which was published in 2018 New England Journal of Medicine. And we can see over here the curves, the Kaplan-Meier curve separated early on, and they remained separated, and there was a huge gap between the curves. And if we see the median PFS, it was 18.9 months with the osimertinib vis-a-vis 10.2 months with the standard of care TKI. So there was a big gap of 8.5 to 8.6 months, and hazard ratio was 0.46, which suggested that there was 54% relative reduction in the risk of progression or death with osimertinib vis-a-vis comparator EGFR TKI. And if we see the subset analysis, we can see over here that almost all the subgroups, they had a good amount of benefit favoring osimertinib vis-a-vis EGFR TKI comparator. So this was the overall survival analysis, which was published in 2019, and it was presented in ESMO 2019. So we can see over here that the median overall survival with osimertinib was 38.6 months vis-a-vis 31.8 months with a comparator EGFR TKI, and the hazard ratio was 0.799 and p-value was 0.0462. And we have to see this, that a p-value of 0.0495 it was determined by O'Brien Fleming approach, and it was required to show the statistically significant improvement in overall survival. And moreover, if we see the Kaplan-Meier curves, so there was 6% OS benefit at 12 months timeline. There was almost 15% OS benefit at 24 months timeline, and there was almost 10% overall survival benefit at 3 years timeline. So the benefit of osimertinib was persistent even at 3 years, and now the later analysis we will see. So this graph is showing that at 36 months, 28% of those patients, they are still continuing taking osimertinib, vis-a-vis only 9% of the patients who are still on first generation EGFR TKI. So there is almost tripling of those patients who are continued on osimertinib. So these patients are those patients who will continue osimertinib for a longer period of time. So this again, time to first subsequent treatment, it is a very important endpoint. So in targeted therapies, whenever we start a patient on targeted therapy, there will be a proportion of patient who will be continuing the therapy beyond progression, maybe because they are asymptomatic or because some local therapy has been given to oligoprogressive disease. So this endpoint, this takes into account all these patients who were continued on targeted therapy beyond progression. And here we can see that osimertinib had a time to first subsequent treatment of 25.5 months, vis-a-vis 13.7 months with the comparator EGFR TKI. And the hazard ratio was 0.478 and p-value was 0.0001, so which was statistically significant. Again, another type of thing that here we can see the first generation TKI, they have a median PFS of approximately 10 to 13 months, second generation 11 to 14 months, and first time there is a EGFR TKI which has shown a median progression-free survival of more than 1.5 years, and which is so it's a cross trial comparison. We do not have any comparison between a third generation and second generation TKI, and this is something which we all know, that osimertinib, it has got the best PFS as compared to other drugs. So here this is a summary of subset analysis of PFS and overall survival, and we can see in PFS analysis, most of the subset had almost equal benefit out of osimertinib vis-a-vis EGFR TKI first generation. But if we see overall survival, so numerically, if we see, so all the lines, they are on the side of osimertinib only. But yes, the benefit, the amount of benefit in all the subset, those differed slightly on the basis of what subset was there. So, but overall, if we look at it, so there was some benefit in overall survival also, which was achieved in all these subsets. So now we will take other generation TKI. So first generation TKI. So these are the Indian studies in first generation EGFR TKI, and they had a inclusion criteria which differed in most of these trials. There were some trial like this Patil et al. Who selected EGFR mutated non-small cell lung cancer. Then next trial they included in a second line where EGFR mutational status was not known. And in third trial, they had selected on the basis of clinical features only. So all these trials have shown those with the EGFR mutation, those have shown a PFS of 8 to 10 months and overall survival of 18 to 20 months. And those patients who were where EGFR TKI was given on the basis of clinical features, so there the PFS was to the tune of 6 months and median overall survival of 12 to 14 months. So these were those trials when osimertinib was not available in the subsequent line. That is why the median overall survival in these trials are 18 to 20 months only. So if we see the second generation TKI, so there are two phase 3 trials which are available for dacomitinib and afatinib. So if we compare dacomitinib trial, which is Archer 1050 with the FLORA trial, so the trial schema of Archer 1050 was that they included the same population which was included in FLORA, except those patients with brain metastasis, they were not included in Archer 1050, and these patients were randomized in 1:1 fashion in dacomitinib 45 milligram once a day plus vis-a-vis gefitinib 250 milligram once a day. And again, the primary endpoint was PFS and the secondary endpoint was overall response rate and overall survival and duration of response and safety. So here the hierarchical design was chosen. So initially they had to see the PFS analysis, and if PFS analysis was statistically significantly better in dacomitinib arm, so next analysis which had to be done was the overall response rate. And if only overall response rate analysis is statistically better in dacomitinib, then only overall a formal overall survival analysis was supposed to be done. And FLORA trial schema we had already seen in the previous slides. So the inclusion and exclusion criteria. So Archer 1050 had included those patients with pre-existing brain metastasis, whereas the stable brain metastasis were included in the FLORA trial. And if we see the efficacy analysis, PFS over here, these are the Kaplan-Meier curves, and we can see, so the curves were hugging each other till the 6 months timeline, and 6 month was the point post 6 month was the point when the curve separated, and then after that they remain separated altogether. So what does this suggest? This suggests that there was some inherent resistance to dacomitinib. In the initial 6 months, there were few patients which were resistant to this, and probably because of that, the curve did not separate early on. And the median PFS was 14.7 months in dacomitinib arm, vis-a-vis 9.2 months in the gefitinib arm. So if we see here in the FLORA analysis, the curve separated immediately, and they remained separated throughout. And the median of PFS was 18.9 vis-a-vis 10.2. So these are cross-trial comparison, but we can see over here that the median PFS with dacomitinib was 14.7 months vis-a-vis 18.9 with the osimertinib. And this overall survival, as we discussed previously also, that this overall survival analysis, it was not a formal overall analysis, overall survival analysis, because overall response rates analysis was not statistically better in dacomitinib arm, and therefore because of the trial design, this formal analysis was not carried out. And here they had shown that numerically it was the overall survival was better in dacomitinib arm vis-a-vis gefitinib, which was 34 months versus 26.8 months. But one thing which we cannot explain is the early the curve was in favor of first generation TKI in the initial 12 months, and later on there was the curves crossed, and then the improvement with the dacomitinib was shown. So we are not able to explain why this phenomena had happened. Maybe there was, as seen in the PFS analysis also, that there were few patients which did not show any improvement with the dacomitinib. So there must be some proportion of patients which are resistant to dacomitinib inherently. So if we see the overall survival curve of FLORA trial, so it separated early on and it remained separated throughout. And at different timelines, the benefit was maintained with the osimertinib. And so this was Canadian consensus guidelines, which showed that Archer 1050 trial had a hierarchical stratified statistical design, and given that it did not meet significance in overall response rate, a p-value could not be given to overall survival analysis, and this was not a formal analysis which was done. So if we see the differences between the Archer 1050 study vis-a-vis FLORA study, so again, this is the patient with brain metastasis, they were excluded out of dacomitinib trial, whereas the stable CNS metastases were taken in the FLORA study. The median PFS was 14.7 months with the decometinib and 18.9 months with the osimertinib. The Kaplan-Meier curve separated after 6-month PFS analysis, and Kaplan-Meier curve of PFS separated immediately in the FLORA trial, and the hierarchical gatekeeping procedure was used, and that is why a formal comparison of overall response rate and overall survival was not significant in Archer 1050 trial. And one most important point with the decometinib trial was that 66% of the patient on decometinib, they needed some dose reduction, and 33% of the patient needed 2 dose reductions. And there were almost 27% serious adverse event, and 10% were the population which had died because of the adverse event. So if we see over here osimertinib, so there were only 3% dose reduction, and SAE were found in 4% of the population, and AE leading to death were only 2%, so which was significantly better in favor of osimertinib. So if we compare afatinib versus dacometinib, so afatinib did not had any overall survival advantage in comparison to the first generation TKI. Archer 1050, numerically the overall survival was more, but it was not statistically significant. And if we see all 3 trials put together, so here in Lung 7, there was some separation of the curve at 12 months timeline, but it was not statistically significant. If we see here in Archer 1050, that the Kaplan-Meier curve separated at 6 months, and but the brain metastases were included in this trial. And if we see the FLORA trial, the curve separated immediately. It was statistically significant PFS and advantage, and even after the stable brain metastases were included in this trial. So now coming to a very, very pertinent question in EGFR mutated non-small cell lung cancer. So that is the patients with brain metastasis, and we can see here that osimertinib is the ideal agent for brain metastasis. Isolated CNS progression, it is a big problem in EGFR mutated non-small cell lung cancer, and whenever we use first generation TKI, so a good number of patients only progresses in brain, and we can prevent these brain progressions if we use an agent which is very, very penetrable into the CNS. This is a preclinical study where we are able to see that there is a lot of uptake of osimertinib in the brain. So it shows that osimertinib has got a very good CNS penetration. And if we see the analysis of both systemic and intracranial efficacy were done in FLORA, and however the Lux Lung 3 and 6 study, they did not the results of intracranial efficacy were not published, and dacometinib Archer 1050 trial, they had excluded those with the brain metastasis. If we see the FLORA CNS analysis, so those patients who were having pre-existing brain metastasis, they had a median PFS of 15.2 months vis-a-vis 9.6 months in the comparator arm. And those patients who were not having any brain metastasis but who progressed in brain, so the median PFS was 19.1 months versus 10.9 months in the comparator arm. So this was the intracranial CNS PFS, which was again reported in the FLORA trial. So FLORA trial did a complete CNS analysis, and they had seen in all possible ways. So how the osimertinib is getting benefit in these patients who were having either pre-existing brain metastasis or who progressed in brain. So we can see over here that the median CNS PFS was not reached in osimertinib arm vis-a-vis 13.9 months with the first generation TKI. So the CNS PFS was again statistically significantly better in osimertinib versus the comparator arm. So this graph is showing that those patients who were having brain metastasis at the trial entry, so 19% of the patient with osimertinib, they had progressed in brain vis-a-vis 43% of those patients with the first generation TKI had a progression in brain. So if we see those patients who were not having any baseline brain metastasis, only 3% of the patients they progressed in brain with osimertinib, vis-a-vis 7%. There was almost double the progression as compared to the osimertinib. So this shows that osimertinib has very good activity in brain in both the scenarios where there is pre-existing brain metastasis, vis-a-vis those who progressed in brain. So this is the NCCN guideline which suggests that osimertinib is the preferred agent for EGFR mutated non-small cell lung cancer. So the tolerability profile of FLORA trial showed that there were only 15% of the patient in which there was discontinuation of the drug because of the adverse events, vis-a-vis 19% with the first generation TKI. So it has got a very good tolerability profile, osimertinib. And if we see grade 3 side effects, so they were observed in 18% of osimertinib arm, vis-a-vis 29% with the first generation EGFR TKI arm. So the main side effects with the osimertinib were the diarrhea, rashes only, and here in gefitinib erlotinib arm also it was diarrhea, rashes, but the LFT derangement was more with the first generation TKI as compared to the second generation TKI, and the grade 3 or 4 side effect, if we see the rashes and acne, it was only 1% in osimertinib versus 7% with the first generation TKI. So the side effect profile of osimertinib is definitely better as compared to first generation TKI. So as per the safety analysis of Archer 1050, so I told you that 2/3 of the patient required 1 dose reduction, and 1/3 of the patient they required 2 dose reduction, and 10% of the patient they died on dacomitinib because of the adverse events. So now, so why do we think that it is important that patient receive osimertinib in the first line? So these are two kind of approaches. So one is the osimertinib in the first line, and second approach is the sequencing approach. So here, all the patient they will get the benefit out of osimertinib. Then the median PFS is 18.9 months, and after that chemo will be given. So again, there will be a PFS of 5 to 6 months. So vis-a-vis those patients who were started on first generation or second generation TKI, the initial PFS of 10.2 months. So there will be only minority of patients who will be a candidate for second line osimertinib on the basis of T790M. So those patients are only going to get benefit out of osimertinib, and rest of the patients, 50% patients, they will not be candidate for osimertinib. So this was another analysis, and we can see like if 10 patients are started on first generation or second generation TKI, almost 73 to 77% patient they will be candidate for at progressions. Almost 3/4 of the patient they will be candidate for T790M testing, and out of those, only 2/3 to 3/4 of the patient they will have some eligible tissue biopsy or a valid T790M result, and out of these 60% of the patients, only 50% will have a T790M positive status. So only 33% of the patient out of these 10 patients, they will be eligible for second line osimertinib. So why to give advantage only to these 30%? We can give the advantage to 100% of the patient, and we can get the best outcome if we are giving first generation osimertinib. So there was this geotag study which was very debatable, that sequential afatinib followed by osimertinib is having the best outcome, but there were a lot of negative things and a lot of bias was there in this particular analysis. So geotag initially, so first of all, it was a retrospective observational analysis, and it excluded those patients who were T790 negative and or who were not tested for this. So they excluded those patients who died on first line afatinib and or those who could not receive a second line therapy. So there was a big selection bias, and the bad patients, so who were not a candidate for osimertinib or who could not take osimertinib because of the poor PS and all, So they were excluded from this this analysis basically. So they had only selected the cream of the EGFR mutated patients, and those patients had like the geotag population was having a 74% of del-19 vis-a-vis 58% in the FLORA trial. So these patients, we know that del-19, they have got a better prognosis as compared to L858R, and they have better drug sensitivity as compared to L858R. So this was again a selection bias was there. The geotag endpoints, the time to treatment failure cannot be compared to a PFS, and it includes treatment beyond disease progression, so which we discussed initially, and the OS was also exploratory. So taking all these points, it is not possible to draw conclusion about the relative benefit of sequential afatinib followed by osimertinib vis-a-vis first-line osimertinib, which was a phase 3 prospective trial. So it is very difficult to say that afatinib followed by osimertinib is the best strategy to use. I think the best strategy is to use a very, very tolerable drug in the first line, which has got the best efficacy and the best CNS tolerability. So to summarize, osimertinib demonstrated a clinically and statistically significant improvement in overall survival. The median OS benefit of greater than 3 years sets a new benchmark for osimertinib, and FLORA is the first time where an EGFR TKI has translated PFS into an OS benefit, and nearly 30% of the patient, they remained on osimertinib at 3-year timeline, and all patient subgroups showed a positive effect in favor of osimertinib. And the most important thing is the safety profile of osimertinib. It remained consistent with the previously reported data, and it has got the best safety profile as compared to the first and second generation TKI. With this, I would like to conclude my talk. And if there are any questions, I think we can take up now during the discussion. Over to organizers. Thank you.
Thank you, Dr. Praveen. So it was a very elaborate talk on oral TKIs, how to sequence them, and what is the best treatment strategy ahead. I think with the availability of osimertinib, which has got such a good brain penetration, and we know that most of our patients, many of our patients, they will fail in brain. I think it makes sense to use osimertinib. So my 2-3 quick questions to you. So have you started using NGS panel, whole NGS panel for adenocarcinoma lung patients, or you are still sending single gene testing?
So now, because I have moved to Akash, so there the availability of NGS reports is not very early on. And if we see the EGFR, ALK and ROS testing also, like single gene based testing. So it takes around 10 days to 12 days time to get all these reports. And the NGS report we can get in 20 to 21 days time. So what I am doing right now is I'm sending NGS in all the patients, and I'm starting off with the first cycle of chemotherapy, and I'm not adding immunotherapy in these patients till the time the mutational profile is available to me.
I think that makes a very important sense, and we can conclude that since the tissue is an issue with all these lung cancers, and you need to have NGS so that you can profile your tumor. I think it makes a sense that you give a single agent chemotherapy or double agent chemotherapy, and then go ahead with the TKI when the report comes. So, what are your thoughts on lorlatinib plus ramucirumab combination? The combination has come up in L858R. Do you feel it has something to do in this adenocarcinoma lung patients?
So see, the thing is that till this time, there is no EGFR TKI plus VEGF directed trial has shown an overall survival advantage. So all these trials, they had PFS advantage, but this was not translated into a overall survival advantage. So the survival results of erlotinib plus ramucirumab is still available, awaited. So I think we will have to wait for the overall survival analysis to come. The other thing is the cost constraint. So if a patient is eligible for, if a patient is affordable for erlotinib plus ramucirumab, so then why not to go ahead with the osimertinib, which is a better tolerable. It doesn't have any injection. Patient doesn't have to come for injections every 3 weekly, and doesn't have this much of side effect which are there with the bevacizumab, this ramucirumab. So there are chances of bleeding, there are chances of proteinuria, wound healing, then. So I think we tend to avoid all these side effects by using osimertinib in first line.
I think most importantly about the CNS penetration, which obviously the osimertinib has the edge. What are your thoughts on complex mutations or compound mutations or uncommon mutations?
So usually for the treatment part, so we categorize these compound mutation or so uncommon mutation, you can say uncommon mutation, into three parts. So one is the compound mutation where compound mutation where there are either EGFR plus EGFR mutation is there, or EGFR plus some other mutation is there, like ALK mutation or MET mutation. So one is the compound mutation. The other one is the drug sensitive mutation like G719X or S768I. So these are those mutation which are drug sensitive mutation. And the third one is the exon 20 insertion. So if we see the drug sensitive mutation, so their second generation TKI, afatinib and osimertinib both works. Then the second type of mutation comes compound mutation. So those compound mutation where EGFR, two type of EGFR mutation is there, and if T790M is a part of that, so osimertinib works better as compared to afatinib. And if we see the third type of mutation, which is the exon 20 insertion, so we have a molecule like amivantamab, which is coming up for this particular mutation, and it has shown very good result in a phase 2 trial, and phase 3 trial is still on with amivantamab.
I think, Dr. Praveen, the list of questions is long for you, but we are short of time. And we'll quickly go ahead